All right, good morning, everyone, and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. Today we are discussing, we're continuing our discussion on House Bill 601, which is Pharmacy Benefit Managers' definition of purchaser and ERISA. And when we left off yesterday, we had folks working on potential language that would clarify what the intent of the bill was in terms of who it applied to see that we made sure that anything we put in the statute didn't conflate with the interaction between carriers for ERISA and PBMs for ERISA, and self-funded and local and state government programs. So with that, I know that MIA was working diligently, and Van Dorsey, I think you developed the language after meeting with a group, and we have your language here today. So I was wondering if you would run through the language, the proposed language, and explain it to us.
Okay, so at a high level, we were asked to try to bring up some language that would do two things. One is to expand PBMs and apply the expanded definition of PBMs to certain provisions of the PBM title, which we have done. And in order to do that, though, we also had to create a definition of for a carrier, which is similar to the old definition of purchaser. And then in certain sections of the title, to make it clear that those particular sections only apply to those entities that it currently applies to. There's additional language that now says that those sections apply to a PBM acting, providing pharmacy benefit management services on behalf of a carrier, which again is the old definition of purchaser. So where those sections and those parts of the title that have that. Those are consistent with current law. So,
Van, hold on just a minute. I'm sorry, but there are a number of people who are not on mute, and so we're hearing your background noise. If you mind putting your screen on mute while Van is explaining the language to us, I appreciate it. Thank you. I'm sorry, Van, go ahead.
Okay. So there are a number of provisions that have been expanded to encompass all PBMs. And those would be those provisions in Part 2 that relate to the commissioner's authority relating to registration, examinations, and the ability to revoke a registration, those types of things. And then the penalty provisions as well, which are in Part 7. In addition to that, there are a number of provisions that were most closely, we were asked to expand, and those are the ones that most closely are tied to the Rutledge opinion. And those are 1628, 1628.1, 1628.2, and 1628.3. In addition to that, there was also 1631, which was also expanded. And I think that captures it all, to be honest.
Okay.
At a very high level. Now we can go through it, line by line if that's what people want to do, but.
Well, we don't have to. Let me ask the committee: is there anyone with a question on the high level And I see your hand, Michael. I'm gonna see if there's any committee members with a question yet. And don't see up. So let me, I know Mike Johansson has some information as well that PCMA reviewed and gave us some feedback. And so I think that's where we want to focus, where the feedback is. So if we look at the document so Mike, you want to speak to the high level, and then we'll go where you have specific comments.
Yeah, so thank you, Madam Chair. Mike Johansson on behalf of PCMA. So we did have a lengthy conversation, and thank you for joining us late yesterday afternoon to have a discussion with the MIA. This approach is kind of the reverse of what we would have suggested, but we understand MIA's approach. We've looked at the language. We'll make a couple comments if we walk through, there's a couple, like 3 or 4 on page by page that we'd like to mention. And I just think for the members, this bill is kind of reverse done. So if you're looking for the MAC pricing provision to make sure it applies to the expanded group or the GER, they aren't in the bill because that means if they're not in the bill, that means they do apply to the expanded group, right? So basically, I think MIA's approach is everything applies to the expanded group of purchasers as the subcommittee requested, which is the ERISA plans and the local government plans, except for things that the bill limits. Mm-hmm. So just for everybody's kind of context as they walk through it, if you are looking for that provision that you really like and you don't see it, that means it will apply more broadly. PCMA, of course, doesn't, support, the expansion, but we're glad you are letting us comment on this process as it goes forward.
Okay. Thank you. And thank you for taking the time to work with MIA and also to give us some feedback. So let's do that then and go through the document. Let me just see here. Brigida, is Delegate Bandari in? He's asking if it's started yet.
I'm here.
Oh, okay. Okay. I just got I just received your text. Saying,
No, yeah, it was like
okay.
8:04, yeah.
Okay. Okay, I'm sorry. So let's look at page 1 and 15-1601, and on the version that I have up on the screen, the sort of lighter red was MIA's, and then what in the sort of darker red was Mike Johansson's feedback. Mike, do you want to speak to this piece?
Okay, thank you. I'm not sure if all the members have what I sent out. I'm looking at MIA's amendment, which has the carrier definition.
Right.
What we had suggested, if you look at, if everybody has the MIA amendment and you go down to the 3rd page, make it the 4th page, which was the old definition of purchaser in the current law. You see that, Madam Chair? That starts at line 10 on the 4th page. If you see lines 17 to 20, this was the language that was kind of the subject of the entire bill, which says purchaser does not include ERISA plans. Our suggestion is, since by MIA's own description, carrier is the new definition of the old purchaser, meaning it's limited to the insurance plans. We believe that ERISA language should be brought up into the definition of carrier on page 1 and simply say, instead of purchaser does not include a person that provides prescription drug coverage subject to ERISA, that it should say carrier does not include a person that provides prescription drug coverage or benefits through plans subject to ERISA. So that same paragraph should move up onto page 1 as part of the definition of carrier. We suggest that because this was really the whole discussion we've had about this bill since the first, since it was introduced and during the bill hearing. Removing the ERISA language means that, in my view, that carrier could now be perceived to be something broader than it was under the definition of purchaser. And we've already made a decision to expand purchaser and apply certain sections to it. If we don't have this exclusion language under carrier, we think it opens up the new carrier definition to that same interpretation.
I actually understand what you just said, and I'm happy about that. But if we pull that, where do we make the distinction between the elements not included in the expansion and those included in the expansion if we define carrier as an entity that provides coverage through ERISA plans? It seems to me that we've brought back in the current operation, which means that the PBMs don't apply, or the rules don't apply to PBMs. So I'm not sure.
So ERISA, so Van can confirm this statement. ERISA plans that were formerly not covered and the local government plans are included in the definition of purchaser. And the way this bill is structured, all purchasers will follow 1628, the MAC pricing prohibition, the GER limitation, the retroactive denial reimbursement, which is 31 limitation, the registration and the penalties and the enforcement provisions. That group will follow those. What we're saying is carriers, including, carriers are subject to the limited set. So, Van.
So, yeah, I perhaps it might be instructive to hear my thinking as to why we took it out, and that is because and this is consistent with other definitions of carrier throughout the insurance article, where it's just describing the insurance entity that is that's subject to regulation by us. And the other problem is, when you talk about a plan subject to ERISA, that is more than just self-funded plans. In fact, any employer-based plan, whether it's through an insurance company or not, is subject to ERISA. So that creates sort of ambiguity. The existing language, and I admit it's in the existing statute. But the existing language does create somewhat of an ambiguity.
And so your
I think what Mike is really trying to make sure that we're not trying to address, and I agree with him on this, is self-funded plans. Whether or not if, for example, if a insurance company is acting as a TPA for a self-funded plan, we would agree that that's not covered under this because that's not really what we consider insurance. But this language is potentially broader than that because the ERISA, we use ERISA as a shorthand for self-funded plans, but it's really broader than that. That's the problem.
Okay. I'm going to go to a couple of questions. I've got Deb Rifkin.
So this is more of an overarching statement, but I just want you all to hear it now. The way I understood what this bill was trying to do, which I thought was to ensure that our law was going to be consistent with the Supreme Court ruling. Now that the Insurance Administration and it looks like PCMA are focusing on the impact to carriers, which is the first time it's been in this bill, and you're changing definitions and where a carrier would essentially fall in to the requirements of this section. I have not reviewed this. I haven't been part of the discussions. I have not looked at it when I'm talking for Care First. And I would ask, I'm diligently taking notes, but I feel like I'm 10 steps behind, and feel as though this potentially could have, want to make sure it's drafted correctly. And I need to have this reviewed. So I just want you to know, I'm not comfortable at this time understanding the impact to carriers of where we're in and where we're out.
So before, let me just explain what I think we want to do here today or this morning, because I want to use the entire 14 hours that we have today to its best advantage for this bill. I know there needs to be some high-level review, both by the national PCMA organizations, and Debbie, you raised that that Care First needs to take a look at it as well. The only thing I'd ask is if we can do this like very soon. I mean, we would really like to see this bill through crossover. We've got like probably 5 sessions that we can somehow make sure that we can, make sure that we can get to second and third reader. To the committee, we are not going to be voting this morning because we are going to give them a chance to review, but I'm hoping that when we get back together later today, probably in the evening, that we'll have information based on the national reviews. The reason I'm willing to do this is because while it may seem like a simple bill, I hope that what we've learned over the last couple of days is there are great implications for this bill nationally. And we are right now in the state of Maryland, in terms of this legislation, moving forward faster than many other states in interpreting Rutledge. So I want to make sure that we can get it as right as we can. And so that's why I'm willing to take a little more time to have that kind of review. And folks were, working on this until 8 or 9 o'clock last night. So, we are trying to, I don't want to move it so fast that it's not as good as it can be, but I would, we are working under a crossover timeline. So that being said, Brian Hose.
Yeah, I think that Mike's definition makes it a little bit challenging because the only place that this applies is where that carrier definition is included. So it's included in 1628, 1628.1, 2, 3. Van went through all of those places. But if you change that definition of carrier to also limit those ERISA plans, you've killed anything that this bill would do, because by mentioning ERISA, you basically make it so that those plans are no longer now included. And it defeats the purpose of that bill. I think it's almost like those places where carrier is mentioned is where it's broad and it applies to everything. Those places where it has that exclusionary statement where it just applies to the PBM acting on behalf of a carrier, those are the ones where it's not applicable. Am I correct with that, Van?
That is generally correct. And to address Deb's issue also, the use of the word carrier generally is where it doesn't expand any of the carrier's responsibilities in the statute. There are a couple of places where the word purchaser was used, and purchaser included, a nonprofit health service plan previously. So those still apply to the Care First of the world. And then the other places where carrier is used is really just as a explanation of the limitation of that section with regard to the PBM to what is current law. So it doesn't, again, and it's an obligation on the PBM, not on the carrier. And it's really the same as current law.
Right. So we're seeing as where it says, PBM or carrier, that's the GER language, that's the MAC language, it's everything related to reimbursement. And those sections are what Rutledge specifically talked about.
Those sections actually are where the only use of the word carriers is where there were specific obligations on purchasers. And so that's why the word carriers in those, but those sections are going to be applicable, are going to be expanded to
Yes.
PBMs across the board.
Right. That's what I'm getting at. Those
Right.
sections where you use PBM or carrier, that is the broad expansion. That's where it pulls in additional places. And that's what Delegate Cullison had asked for in her understanding. So if you change the definition of carrier to talk about ERISA at all of a sudden now you've made an exclusion, and that is not what Rutledge was talking about. They were saying be silent on ERISA and it applies. Talk about it and you've opened the box.
Thanks, Brian. Kim Robinson?
Thank you, Madam Chair. I guess listening to the back and forth just now between Mr. Hose and Mr. Dorsey, I guess when Mr. Hose started speaking, his first statement was where it said that the provisions of 1628, 1628.1, 1628.2, 0.3 and 31 were narrow, but I think in the conversation they got back to what the bill is actually structured to say. Those are actually the broad provisions, not the narrow provisions. So I was just confused for a second because he started off with the proposition that those were the narrow provisions. And I think it's actually the opposite. Those are the broad provisions that apply everywhere. I think to Mr. Johansson's point, what he was looking for was the purpose of the carrier definition was to be the current purchaser definition. I think that there's probably some room for discussion with the MIA. I mean, I think it's one thing if they interpret, if it's clear that they will interpret carrier as they do throughout the rest of the insurance article, which clearly does not reach self-funded plans, and that there is not space for someone to interpret this new carrier definition as broader than the previous purchaser definition. I think that's what PCMA is guarding against, right? Because now the definitions, whereas the carrier definition is meant to essentially be the equivalent of the old purchaser definition, but it's not identical, making sure that they actually say the same thing is why that absence is creating some question. And so I think that's the really necessary assurance from the MIA is that that definition is going to be interpreted identical to the previous purchaser definition.
Thanks, Kim. Mike, you want to follow up?
Thank you. I guess I'm just trying because I'm getting myself confused, and you know I apologize for that. But just to be clear, MAC pricing, okay, applies to everyone, right? The broadest expansive definition. Therapeutic interchange, on the other hand, for example, only applies to carriers, a more narrow definition, right? I think we all agree with that concept at the moment, right?
Mm-hmm.
And the reason that carrier needs to be defined as not including, I'll use Van's word, the self-funded plans run by a TPA that may be also an insurer, right? And Aetna, for example, that runs someone's self-funded, plan. The reason that they should be excluded from the definition of carrier is because the therapeutic interchange provisions only apply to carriers. And if we don't have that exclusion language, we would then be saying that the therapeutic interchange provisions now, for the first time, apply to self-funded plans run by TPAs. So that's the little bit of, I think kind of just we need to understand how the bill works so that then we can draft the language to make it clear. But that's my understanding.
Okay. Commissioner?
Just briefly, in the interest of time, I don't think, at least from the MIA's perspective, that we disagree that self-funded plans are intended to be carved out from the definition of carrier. And we'd be happy to work offline with others to create that clarity. We don't think that this particular iteration does it, but we are happy to work on language that we can get to agreement on with regard to that concept.
Okay, I appreciate that. And since we know we're gonna take some time today to get some national review, then I think, we've got a little bit of time for that. Steve Weiner?
Okay, thank you, Madam Chair. I guess, so I understand the changes and I appreciate the MIA going over them. It was my impression, and maybe I was wrong, this process started out, I guess it was broad, and we were told, unrelated to payments shouldn't be included because of the Rutledge decision. And then I was under the impression that were directly related to reimbursement, like MAC and GER. That was the intent by the sponsor and later on by the committee to make the reimbursement provisions to expand those. I don't understand why the self-funded plans now in those sections are not relevant. I think someone mentioned earlier, ERISA and self-funded have been used interchangeably, maybe not legal definition, but in vernacular for years. So again, this bill has been whittled down to affect just the payment provisions.
Steve,
yes.
the language does apply MAC pricing and GER and retroactive reombrsement denials to self-funded plans and
Right.
all other purchasers.
Right, and that,
Yeah.
so, and the comment just a moment ago from the MIA, did I misinterpret that to say, okay, we don't intend to apply those provisions to the self-funded plans, or we're just talking about the other provisions?
You misinterpret that one, buddy.
Yeah.
Okay, I apologize then, and I just take back everything I just said for the last 4 minutes.
So Steve, I think, part of the challenge and it's just the way that I think we need to look at this bill is that it's sort of the reverse. And so it's defining what it's trying to make inclusion and then exclusion, and which is tricky to do when you have you're trying to separate something that is so intertwined when you're talking about the relationship between an insurance carrier and a PBM, because that's a really pretty intertwined relationship. So that's why it's tricky. But Delegate Kipke is right. What you're looking for, this includes the self-funded.
Okay, and I thought that now,
right.
And the MIA's version that we're presented with appears to somewhat be future-proof, which is nice. So the concern is if we do the opposite, where we specifically list certain things, it was suggested to sort of flip it around. My concern is that really locks it down, and then we'll change them. Instead of an HMO or an MCO, we'll have a health CO or something else that won't apply. So the way it's written, although we'd like it to be broader, we can live with. If it was flipped around to really tighten it down to just plans and pharmacies and patients who live in 2120, that's our concern, that it'll somehow get drilled down to that. Thank you.
We're working on it. Brian?
Yeah, I'm sorry, Steve made the comment that I was going to make, so we're fine.
Okay, so what I'm hearing then is there needs to be more clarity with respect to the, how we make sure that the overlap with ERISA with plans and benefits is excluded from this and so we need to do some more defining, more clarifying in the definition of carrier and where the word purchaser applies. So, and I hear the MIA is willing to work on that offline with folks. Mike, you want to talk about other issues with the
Can I
language?
comment on this before we go on to Mike again?
Oh, okay, yeah, sure.
This is David Can on behalf of Epic Pharmacy and independent pharmacists. My understanding of what MIA was trying to do was to narrow the scope of the provisions other than reimbursement provisions to those types of entities that it has jurisdiction over, that it regulates. And my understanding is that it does regulate TPAs in many different respects. So I'm not sure that excluding TPAs and plans that are managed by TPAs makes sense in that context.
Van, do you want to respond to that?
So we do regulate TPAs. However, the TPAs that we regulate are those that act as TPAs for insurance plans. ERISA plans, self-funded plans, are specifically carved out of the, for example, of the registration requirements for TPAs. All a TPA that acts on behalf of self-funded plans has to do is submit a letter to us, actually, and they're not subject to that subtitle.
Okay. Okay, so I want to see what other outstanding areas we have before.
So Madam Chair, the next comment I had was on page 4. If anyone has something before that, maybe they could raise it, but.
Okay. Well, let me go back. So we addressed the issue that you identified on page 1 is related to what we were just discussing.
Correct.
Right, okay. So we're looking at page 2. Are there any comments on, looks like mostly existing language or that's been struck?
Correct.
And then page 3. Again, existing. And okay, down to page 4.
So, Madam
Okay.
Chair, on page 4 is the new definition of purchaser. It is very expansive. We agree that lines 17 through 20 should be stricken as they are. That's the ERISA language. And we just thought, for clarification, since it's kind of such a weird construct where we have purchaser here, we define carrier above, we had recommended simply saying at line 17, purchaser includes a carrier defined in C1 of this section. I think it does already. I don't think there's any disagreement, but I just think it helps the reader understand this whole subtitle now.
Van, do you see any issues with that?
I don't think the MIA has any technical issues with that now.
Okay, then we can do that. And last page. Anything on the last page?
Well, when you say last page.
Well, it's not actually the last.
Yeah.
It says 505, but it lied.
I didn't have anything again until
Yeah, I don't see. Here we go.
the page that has 15-1613.
Oh, 1613.
And actually in 15-1628.
Oh, wait.
Okay, yeah, it's 1628 is where I see your comment.
Okay. So 1628 is the filing provision and the mandatory 30-day notice to pharmacists. I don't have any questions with respect to A1. When we look at A2, we're talking about credentialing requirements. And A2 little 2, 2I, it says for purposes of credentialing a pharmacy or a pharmacist as a condition for participating in a pharmacy benefits managers carriers network. I'm wondering if that should say condition for participating in a pharmacy benefits managers network for a carrier. I think it's technical, but I think it works.
It's actually it's actually supposed to be in a pharmacy benefit managers or carriers network, which is, and that tracks the language that is in the existing statute. So essentially we're just substituting the word purchasers for carriers.
Okay.
Does that work, Mike?
Yeah, this is one of those ones where I think the circle's spinning the full 360 on this one, so it's very hard to understand the exclusion. Van, could you try and explain to me how this keeps it to carrier?
Well, all this, the existing language of the statute imposes the obligation both on, well, mentions both the PBM's network and the carriers network. And so and the purchasers network. And so all we did was substitute the word purchaser for carrier.
No, I appreciate that.
And I think that if you used your language, what that would do is it would take out the concept of the PBM's network.
Correct. But if we leave in the PBM's network, what's not to say this isn't the PBM's network for a local government plan? And therefore, the PBM's network for a local government plan would be, for credentialing purposes, would be not able to credential every 2 years. I'm trying to limit this provision to only be for a PBM network related to services performed for a carrier, which I think is the intent, as compared to a PBM network for services performed for a local government plan, which now extends this limitation on or restriction on credentialing to local government plans.
That's going to be a policy call for the committee, whether they want to limit this particular provision or not. I mean,
our suggestion is this is the credentialing process is not a rate regulation process. So to be consistent with the initial theme, I think this should be limited to the network of a PBM that's providing services to a carrier.
And not the PBM's network.
Yeah, if it's simply PBM's network, then it opens it up to the PBM's network for anyone that they're doing.
Right.
And I think it needs to be the PBM's network for a carrier is consistent with how this bill is structured at the moment, recognizing I think some of these things will come back next year for more discussion.
Right, right. Van, what do we lose by just using for a carrier? Network for a carrier.
So you will lose this particular section will not apply to the broader PBMs. It will only apply to the PBMs, acting on behalf of a carrier.
Doesn't it make it narrower than the current law?
Well, the current law only applies to purchase. I mean, only the PBMs themselves only act on behalf of purchasers, which is
the current law is pharmacy benefit managers or purchasers network. It's both.
Right, but a pharmacy benefit manager is defined to include the purchasers. So I mean, That's why it's more narrow.
So admittedly, I'm just trying to keep this as current status. I'm not trying to limit it more than previously. And happy to have a further conversation with MIA and Lisa to make sure the words are right. But if the thought was this bill is intending to expand 1628 and GER and MAC and the others, the way it's worded now, this is an expansion that wasn't previously described.
So I guess we just need direction from the committee on how you want it to be, and then we can work out the technical language.
Certainly Rutledge did not suggest, ERISA plans can have their credentialing processes restricted, in my view.
And you think this the MIA's language would do that?
Yes.
Would bring in credentialing piece. So given my interest to make this as clean as possible, okay, let me see. I've got a couple of folks who want to say something. Let me hear what they've got to say. And if there are committee members who have questions, make sure to use your participant hands. Kim Robinson.
Thank you, Madam Chair. Mike just made the point that I was going to make, which is I think that this is the one piece within this particular statute that is not rate regulation specific. And I do think that there is an argument that this is transferring over into plan and benefit administration, where we're getting outside of the rates when it becomes the process of building the network, which is what credentialing is a part of. And so I think to the commissioner's question, I think is actually a good one. I think ironically, the way it was drafted before was kind of redundant to Van's answer, which is that the way PBM was previously defined, it only applied to the state plan and carriers. And now, and then repeated carrier after that, or repeated purchaser, which was the state plan and carriers. And so it sort of said the same thing twice in that way. I think it was attempting to contemplate that perhaps the purchaser had their own, somehow the purchasers network was separate from the PBM, but I don't think that that was really rooted in reality. But I do think that the way it is currently drafted, because now that PBM definition is the broad definition, carrier now being the narrow definition, it is expanding beyond that appropriate scope. And so I support Mr. Johansson's recommendation.
Okay. All right, Brian?
I just want to remind everyone that typically we've had these discussions before around the credentialing piece, and credentialing is used as a way for the PBM to collect fees from the pharmacy or delay entry into a network. Pharmacies are credentialed by the Board of Pharmacy in Maryland every 2 years. So this isn't something where we feel that it should be, they should be allowed to just credential every year, collect these fees, and tie up pharmacies' time. Typically these things, we got one right when COVID started from one of the PBMs, and it takes, an hour or so of very high level employees' time to go through and provide all the same data that was provided the last time. And then you pay a fee to them for the benefit of providing the same data that they already have. So it's not like they're using this credentialing piece to do anything other than charge the pharmacy a fee, waste a bunch of our time. And the pharmacies are already credentialed by the Maryland Board of Pharmacy on a regular recurring basis. So this process is not one that is doing anything other than tying up pharmacy resources. And it's one that we believe should be stopped. So if Maryland could step out of the boat a little bit here with the Rutledge stuff and put a stop to some of this stuff, we would really appreciate it.
So I'm still not clear on, it seems to me that if a carrier is establishing a network, the carrier would have a role in credentialing a pharmacy that they're going to be working with, and that PBM is the intermediary between the carrier and the pharmacy. That's current practice, right?
I think it's better to say that the PBM is the one who solicits pharmacies to be on the network. It's the PBM's network more than it is, and because carrier here is the plan sponsor, put them at the higher end,
I
right?
see.
So the
Okay.
State Employees
Right.
Health Plan, DBM, they're hiring a PBM, and the PBM is going out and building the network, credentialing pharmacies, entering into contracts, whether it's through the other intermediary called a PSO or not, it's a different issue, but it's not the State Employees Health Plans network. They don't own it. The PBM typically contracts with it.
If you just want to talk about, if you just want to regulate the money, if you just want to regulate the money piece, make it so they can't charge a fee for it. It'll stop.
It's a great
Do
conversation
you have a
to have
response,
next
or
year.
your hand's just not down? I'm sorry, Mike, I missed what you just said.
I think it's just a great conversation to have next year. We're going to have it. I thought the purpose of this bill was to move something that was limited in its form. It's setting up a structure that's going to now engender a conversation on every one of the other specific provisions and more. And that's a conversation I think that the committee can have next year with appropriate fiscal notes, and everybody has a chance to weigh in on how it impacts them.
Mhm.
But I think technically the suggestion I made fixes this from being more expansive than was previously described.
Okay. And I think, and I know, Brian, you were addressing the issue around credentialing, but I think I'm moving in the direction of Mike, because if credentialing is an issue, let's deal with credentialing, not in.
We just don't want it to be more restrictive than it was before. So if it's going to be the same as it was before, as far as this section.
Yeah, I think this keeps it the same. Is that, Van, am I right? If we do the network for a carrier, it keeps it the same. It doesn't reduce the oversight.
I think it does keep it consistent with the current
Okay,
requirements.
then, okay, let's go there then, unless anyone on the committee has an issue with that. Okay, next issue.
Only one more for PCMA at this time, and as I think maybe Kim mentioned, this has been sent out to all our members. They're obviously going to be sending back comments. We will send them to MIA and staff right away. I think they would be mostly technical at this point, but the only last question or comment that we had would be the very end of the bill, the applicability section. We would suggest the standard insurance language, which is a January 1 start date and applicable to policies, contracts, and health benefit plans issued, delivered, or renewed in the state. It doesn't say contracts between PBMs and pharmacies, okay, issued or renewed after that date, because this bill would apply to the payers and their new plans. So for example, if Calvert County has an employee plan that starts July 1st, this bill, even if it takes effect on January 1, won't affect Calvert County and its PBM and how it has to set up its plan until that next plan start, which would be July 1st. Municipalities, counties all have different dates. Obviously, ERISA exempt plans may all have different start dates. And this is similar to the PBM bills that have passed in the last 5 years, have all had the same language.
Right. Steve?
Yeah, there are certain, I am told, there are certain contracts that just sort of amend and never are rewritten. And our concern is that they won't be caught up if you do that and don't put a firm date. They're just sort of lightly amended but not rewritten, and that would somehow get around this obligation. And I could be wrong. I'm not an attorney.
Mm-hmm.
Steve, can you confirm, are those contracts between the payer and the PBM, or are they contracts between the PBM and the pharmacies?
I'm talking about contracts between the PBM and the pharmacy/PSAO.
Mhm.
So, for instance, there might be a PBM that's had a contract for over 10 years that isn't really ended, but it's slightly amended from year to year.
Yeah.
And so again, I'm not an attorney, but my concern is somehow those aren't caught up in this, and there should be a firm date.
My understanding of how this would work, and again, I'll look to MIA to confirm or refute this.
Yeah.
But if Calvert County starts a new employee benefits pharmacy plan on July 1st of 2022, if PBM, Mike Johansson, have a contract with you that includes GER as of July 1st, 22, and now I'm contracted with Calvert County, for those Calvert County employees, I can't do GER with you. Right? So to me, even if I haven't changed my contract, for the payers or the ERISA plans that now are subject to this, when they renew their contracts or their benefit plans, honestly, then I can't impose those provisions such as MAC pricing, GER, retroactive denials. That's my understanding.
But you will be able
David,
to go. Anyway, go ahead.
David Cooney may have some information on here, since he's one of the guys who's been looking at contracts.
Sure, and I'll defer to Van on some of what Mike said, but to both Mike and Steve's points, those were both things we considered. Mike made a comment that this is the same language that's been in the past several PBM bills. It wasn't the bills last year, but I actually this morning went back and looked at various PBM bills over the past 10 years, and this language isn't typically in there because this is language that we customarily see for bills that specifically impact insurance contracts. That's why it mentions health benefit plans. And it has been in at least one of the PBM bills, like the one from last year. But if you look back at the other ones, the uncodified language, it varies. And to Steve's point, sometimes it specifically makes the point to say it affects in-force pharmacy benefit manager contracts to make sure that those provisions go in immediately. So, I mean, it's going to be up to the legislature how exactly you want to handle this. But I think the MIA does have concerns with the Section 2 language, that it does leave open the possibility that if you use that language, there's going to be an argument that some of the provisions will never apply to certain contracts because they're evergreen and they do not renew and things like that. So this is not, we don't feel that this is the most appropriate language for the effective date for this bill.
Okay.
And just to clarify, what I'm trying to prevent is Calvert County that contracted July 1 now, right, that has an existing contract with a PBM that doesn't expire until July 1 of 22. I don't want in February 1st, Calvert County to have to change its existing agreement that they've negotiated with their union. They have cost sharing with their employees. And if you say they can't use a GER model with their PBM and their pharmacies, it changes someone's economics. So I'm not trying to necessarily prevent the changes applying between the PBMs and the pharmacies.
Jumped in here.
I'm trying to deal with it between the plan sponsors and the PBMs, like a health plan or an insurance contract.
Right, and I just think we need to tweak the language. I understand what you're saying, and I don't think I think the language you propose has unintended consequences of maybe doing what you want and also having some other impacts also.
It's intended consequences.
So we already know that MIA and PCMA is going to be working on the purchaser carrier issue. So can we work on this as well to see if we can clean it up? Are there, I've got a couple of people. David Can.
You're on mute.
I have a couple comments on the proposed text. I want to make sure I give you the correct page. section 26 point or 1628.3.
Okay.
I don't know where he is, but that's all right.
On the 7th page, excuse me. 7 out of 10. This seems to exclude the pharmacy benefit manager's responsibility with regards to reduction in payments solely to when it is acting on behalf of a carrier rather than a purchaser. And I don't think that was the intention. The intention was to apply 1628.3 broadly to all PBM activities, whether on behalf of a carrier or not. So I think that the term purchaser should still be used in there instead of carrier.
I think that's what they're going to be working on to clarify. But Van, do you want to respond to that?
Sure. The reason we took out purchaser in that case, it's still an obligation on PBMs, and it's the broad PBM definition, David. And it's not acting on behalf of a carrier. It's PBMs. But the reason carrier is in there is because this statute currently imposes obligations on purchasers. And frankly, we did not want to be in a position where we were having to have enforcement obligations with regard to self-funded plans. So that presented a problem for us. And whereas if you use the word carrier, which is consistent with the current use of the word purchaser, it imposes the obligations on the carriers, which they already have in the current law. So what we've done here is you've expanded the definition of PBM. So the PBMs themselves have their obligations with regard to self-funded plans, but with regard to our obligations on a purchaser in terms of enforcement, it's only on the carrier. Does that make sense?
It makes sense. Is there any reason why we can't include the language on its own behalf or on behalf of any purchaser?
Oh, it seems a little redundant. Van, can't we just get rid of purchaser and carrier in those two paragraphs?
So we were getting rid of the word purchaser. If you get rid of the word carrier, all that does is it removes the obligation from the carriers and
leaves it with the PBM who
leaves it with the PBM. So that would be a change in the existing law. That's all.
Yeah.
Yeah, I'm certainly not proposing that, but I want to make sure that the pharmacy benefit manager in all its activities is subject to this law.
Right. It's not the pharmacy benefit manager acting on behalf of the carrier. It's pharmacy benefit manager or a carrier. So it's the expanded version because PBM definition includes purchasers. It's the expanded version of PBM.
And then one other comment, section 1612. Trying to give you where that is. Page 5 of 10. This provision directly addresses reimbursement. So I'm not sure why it needs to carve out PBMs that are acting on behalf of parties that are not carriers.
Van, I'm going back to you again. I think it's the same reason that we just spoke about, but
this was carved out because it was our understanding this was what we were instructed to do. to be
Oh,
honest.
right. This is, okay, I see. And now I'm looking at it more carefully. Yeah, this is, we wanted to, this seemed to go beyond what I was looking for in terms of narrowing the scope of the bill. So that's why that's carved out.
Isn't that a payment section?
Yes, it is. It applies directly to reimbursement. PBM may not reimburse a pharmacy or pharmacist less than it reimburses itself or its affiliate.
It's payment.
So we would essentially be saying that they can, we would essentially be saying that they can pay themselves more in any of these ERISA-based plans. So it's okay for them to open up the piggy bank when it's paying themselves on these plans, but not on the plans that are fully insured or were previously regulated. So this is directly reimbursement and self-dealing.
Well, it may be self-dealing, but it's not, it has an indirect relationship to reimbursement. This is the issue of, again, looking at the relationship between the plan and benefits piece and what the PBM activity is, and whether or not the plans, or whether or not the payers are having, the PBM is part of the payer or not, as I understand this piece. So that's why this was pulled out, because I was worried that there was too much interaction in this piece around the relationship between the plan and benefits.
Okay. It defies common sense. Oh, I'm sorry. I didn't realize my mic was on. I apologize for that comment.
It's okay. Kim?
Hi, Madam Chair. My hand went up earlier in the conversation, so I'm just going to back up for one point. And I appreciate the possibility that Mr. Cooney left to talk about the effective language. I think to Mr. Johansson's point, because this is now going to bring in government contracts, if you think about even how the state employees plan does its negotiation for benefits, when they're paying attention to bills, they will often come to you and ask you to moderate effective dates, because those negotiations and the way the pricing is built into them and the way that they're funded, being that they're government plans, has a really specific impact. And so the goal is not to protect like evergreen contracts. The goal is not to take counties who are beholden to their budgets and upset their apple cart midstream. So I appreciate the MIA's suggestion that maybe there's a conversation to be had about that, so that, again, because we know they're not at the table here to talk about their contracting cycle and what it's going to mean for them economically to have to make the change midstream, and what their sort of body of law in terms of how they're negotiating again with unions and all of those sorts of things is going to impact everything for them. I think it's a conversation that ought to be had.
And with that, I'd like to send folks off to have the conversation. So I think we've gone through the bill, unless there's any other outstanding issue or question. I don't see any other hands. So committee, I need you to watch your email today, because I expect that we're going to be getting back together to look at some other proposed language. I think that we're pretty close. As you've heard, there's there are two sort of outstanding issues that MIA and PCMA are going to work through, and we will hopefully get a chance to look at that and evaluate if it's ready for us to vote on this later today. Are there any questions of me before we adjourn? Okay, seeing none, thank you all for being here, and we go on the floor today at 12 o'clock, and I will see you all later. Thank you all for participating.
Thank you.